Today's topic is Clinical Trials 101. This topic is one that I'm really excited to have talked about today. I think clinical trials can be such an important part of a treatment plan, and they play a huge role in how research is moved forward and we get closer to a cure. Most people don't really, in a detailed way, understand how clinical trials actually work until you're put in a situation where you have to learn the details. And in the case of a cancer diagnosis, understanding how clinical trials work and being able to separate fact from myth is important. But when do you have time to sit down and research it when life has just been turned upside down? So today we're going to take a second to learn about clinical trials and hopefully answer any questions you may have around this really important topic. Let me take a moment to introduce our speaker today, Logan Murray. Logan Murray attended the University of Florida for his bachelor's degree, master's degree in physician assistant studies, and graduate work in clinical training as a physician assistant. He subsequently moved to Tampa, Florida, gaining experience treating a variety of diseases, primarily acute leukemias, lymphomas, and multiple myeloma. Logan thoroughly appreciates the complexity of hematologic malignancies and the care that patients require. I first met Logan early this year when he participated in interviews for one of our other educational programs, HealthTree University, and I am so excited to have him here with us today. With that, I'm going to go ahead and turn the presentation over to him.
Okay, let's see. My screen should be shared.
Yes.
Okay, cool. Well, good afternoon or morning. It is the afternoon here in Tampa, Florida. Again, I really appreciate the opportunity to be here. Let me close this, sorry. I thoroughly enjoy getting to do what I do. So a little bit about me. I work at the Tampa General Cancer Institute. I have been practicing in blood cancers for 5 years now. I started at the Moffitt Cancer Center here in Tampa, Florida, and worked and trained there for about 3.5 years, and then had a unique opportunity to join the TGH Cancer Institute, which is only a few years old, and it's on that little island there in the heart of Tampa. But I've fallen in love with getting to work and serve AML and MDS patients, and like my introduction said, I did have some experience in lymphomas and myelomas, but over the last year and a half, I have focused predominantly on AML and MDS, where we work with a variety of clinical trials and treatments, and we work very closely with our community here in the Tampa Bay region of Florida. So enough about me. I will jump right into it. So as Mary said, I have the unique opportunity to talk a little bit about clinical trials and why they're important. Clinical trials have a gross misunderstanding at large in the medical and non-medical communities. So I'm hoping that I'll be able to kind of alleviate some concerns, shed some light, and hopefully spark some conversation and questions moving forward. But before I talk about trials, just a brief kind of snippet about the diseases that I get to treat and that we'll be focusing on today. So myelodysplastic syndrome is a disease that we see quite a bit of. It is a blood cancer. The debate is starting to settle down, but it used to be just called a syndrome as it is in its name, but it's now become known and understood as a blood cancer. But how we describe myelodysplastic syndrome to our patients is the bone marrow, which is kind of the pulp within your bones, is the factory of all your blood cells. And the production of your blood cells in myelodysplastic syndrome gets disrupted, and dysfunction happens. We kind of equate it to a assembly line, and normal functioning marrow, the assembly line works well, but in MDS, once certain mutations and chromosome changes happen, that can lead to bad stuff coming off the assembly line and dysfunctional product coming off the assembly line. So patients with MDS, they kind of present in a wide variety of ways. We see some patients who don't know they have it, and we see some patients who they have to go to the ICU pretty quickly. The big symptoms are related to the low blood counts. So whether that's a white blood count being low, putting them at infection risk, their red blood count being low, putting them at risk for symptomatic anemia, or their platelets being low, putting them at risk for bleeding. And, I'll touch on treatments in a little bit, but we have a kind of a handful of drugs that we get to use, and that ranges from, really what we would call supportive therapies to chemotherapy to then allogeneic stem cell or bone marrow transplant. And then shifting gears a little to acute myeloid leukemia. You'll notice the myelo and the myeloid, these diseases are very, they're related in a way. And some people will describe them on a spectrum, but AML or acute myeloid leukemia is a much more aggressive form of blood cancer, where the factory of the cells isn't just making dysfunctional things, it's making bad leukemia cells, and a lot of times it's making them in an overabundance. And very quickly, over the course of weeks and sometimes months, this disease moves quickly and it eventually leads to bone marrow failure. There can be what we call extramedullary involvement, which means just outside of the bone marrow. So in the nervous system, in the skin are two of the more common areas when we do see that. And these diseases require chemotherapy. And I'll kind of touch on treatments for that in a little bit too. Okay. So just some more tidbits about the diseases. You'll see both diseases, the median age of diagnosis is kind of in the late 60s, early 70s. And then we see in MDS about 10,000 to 30,000 new cases per year. This is something that I think will only increase as our population kind of ages. MDS specifically is a disease of aging. And then we also have better detection capabilities. And I think there is a growing understanding of what to look out for in a patient that may or may not have MDS. And kind of like I said, there's a wide range of presentations and treatments. Some patients never go on treatment, and that's going to be dictated by a variety of factors, while some require treatment started within a few weeks. And again, that includes transplant. Then AML, most common type of acute leukemia in adults, not to be confused with acute lymphoid leukemia. There's about 20,000 new cases per year in the US. I believe here at Tampa General, we're on pace to see about 150 to 175 new cases of AML this year alone. So all cases of AML require treatment. Otherwise, they are fatal. And then we would kind of describe most cases as incurable in the absence of a bone marrow transplant or stem cell transplant. However, there are a small group of AML cases that are potentially curable without a transplant. That means with chemotherapy alone, which is very exciting. So another thing that I wanted to mention is remission for AML patients is relatively easy from an investigator and a provider standpoint. We can offer therapies that can get patients into remission. However, the challenge with this disease is that the disease comes back and relapse happens. So keeping a patient in remission is a huge challenge, and there are a ton of unmet needs there. So I put together a list of therapies for both MDS and AML. These are not exhaustive lists, but just to try to give you guys a kind of a little, visual at how many treatments we have available. These are the, available therapies for MDS. There are some things that we can use off label, but for the most part, this group of about 6 types of drugs or 7 types of drugs are the drugs that we use most commonly. So at the top of the list, we see some chemotherapy agents, although we would kind of describe these as lower intensity chemotherapy. In the middle with luspatercept, imetelstat, and some erythropoietin stimulating agents. It's like Procrit and darbepoetin or Aranesp, Retacrit. These are drugs that we use in lower to intermediate low risk MDS that really we're using to support the patients. So by that we mean support the problem that the MDS is causing. And in the case of these drugs, it's largely the anemia. So the low red blood count, we give these drugs to try to make it better. And in the bottom, Tibsovo or ivosidenib is the only targeted treatment that targets a gene called IDH1 that we see in a small population of MDS. And this is a little bit more involved list of therapies for AML. Again, not exhaustive. There are a lot of other chemotherapy agents that I left off the list, but my 5 years of treating AML, these are really the drugs that we use. At the top left are the higher intensity chemotherapy options. The very first one, arsenic and atra. Those drugs are going to be used for a specific type of AML called APL. And that is a curable form of AML. It's actually one of the deadliest forms within the first 60 to 90 days of diagnosis, but there's a very high cure rate, close to 85 to 90% with just this regimen of arsenic and atra alone. The one thing I wanted to highlight was gemtuzumab. Gemtuzumab ozigomycin is the full name of it. We'll use that in combination with the high intensity chemo, or we will use it single agent, but you'll notice the last four letters are MAB. This is a monoclonal antibody that targets a marker on the surface of the AML cells. And I bring that up because of huge unmet need in AML and MDS are the lack of immunotherapies. These are therapies that are prevalent in all types of other cancers now. You'll see them on TV commercials all the time. Even in other blood cancers like ALL or lymphoma, we have monoclonal and bispecific antibodies that can harness our own immune system's ability to fight the cancer. And with that, we get better tolerated treatments, less toxic, and very, very effective. But that is really one of the only antibody-directed therapies that we have in AML. And below the high intensity or low intensity options, you'll notice there's some overlap with the MDS, and then a little bigger list of targeted therapies that we have going at different mutations that patients with AML have. And this is just a quick visual. I put it here just so that there's another visual to see from 1970 to 2010 over the course of 40 years. Only a handful of approvals and kind of advances in the treatment of AML, but you'll notice in the last 8 to 10 years, we have really kicked it up a notch in getting more tools in our tool shed when it comes to treating AML. So why are clinical trials important? They're incredibly important for a wide variety of reasons, but I wanted to start here. So for higher risk MDS patients, these are patients who we would consider intermediate high to very high risk. That is the median overall survival, 0.8 to 3.7 years. Anybody diagnosed with MDS, no matter how old they are, will generally that will be jarring and that will be unsettling. So we want to have more therapies available, a better understanding of the disease so that we can stretch that out as long as possible, whereas lower risk MDS patients are living 8 to 10 years on the median overall survival. So we'd like for it to get closer to that. And then in AML, I use this statistic, 29.5% 5-year survival rate for AML, or the median 5-year survival rate. And just for some context, I showed that slide previously with all the advances that we've made and the progress we've made. In the 70s and 80s, that number was less than 10%, closer to 7 to 9%, depending on where you look. So, at 29.5, it's certainly very low. It can be a lot better, but we've made a lot of progress, over tripling the 5-year survival rate just with some of the help from clinical trials. So this slide, I use some cute pictures to try to highlight some common misconceptions about clinical trials. So top left, that is a guinea pig. And that is probably the first thing that comes up when we talk to patients about clinical trial. And they say, I don't want to be a guinea pig. I don't want to be experimented on. And there's a huge gap between an experiment and a clinical trial. A clinical trial is very meticulous. It is very, safe. And there's a ton of monitoring that makes sure that, it does not start to feel like a science experiment. Also, by the time that these drugs get to phase 1 to first in human trials, they've been used on guinea pigs. So, these drugs have been looked at, very thoroughly to ensure safety in humans before it's even given to humans. So that's a huge misconception that, we need to try to dispel. The next one, I've never read this book, but it was pretty, and it said what I wanted to say, which was the last resort. Sometimes when we bring up clinical trials, patients say, whoa, 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 like we're not there yet. Meaning, I only thought you needed to go on a clinical trial if you were at the end of the rope. Clinical trials, should be used front line, second line in these diseases. And I'll kind of touch on why that is in a bit. But trials are not last resorts. Trials are available all the time from the moment a patient is diagnosed. And then the best clip art I could kind of find for placebos were these pills. Some reasons why patients don't want to go on clinical trials is because they think that they're going to get nothing. They think they're going to get sugar pills for their very serious blood cancer. Um, you can get a placebo on a clinical trial, but that would most likely occur in like a phase 3 clinical trial, and you will be getting standard of care with it in these diseases. We will not shortchange you. Clinical trials are not trying to trick you. They do not want to make you think you're getting therapy and then you actually get nothing. At the very minimum, patients on clinical trials get standard of care therapy, meaning they're getting what everybody else off the trial will get. But with some of these trials, they will add on new agents with that. And then I put this referral piece here because a lot of people think that they need a referral. And I think it's very important that patients are very involved. And that's why I love what HealthTree is doing, just trying to educate patients to the best of everyone's ability, because patients need to know that clinical trials are available. And at the very end, I'll kind of give some resources that can kind of direct patients towards where to find these clinical trials without having to go through, a physician. And then the one of the maybe the elephants in the room, the money behind clinical trials. A lot of people think it's incredibly expensive, and if you're going on trial, a lot of times there are funds that are available to cover a lot of the outside costs, whether that's travel or lodging, and the treatment itself. For the vast majority of times, especially or at least in the trials we're giving at Tampa General, the treatments themselves are being covered too. So these are just some truths about trials. I think trials should always be considered in most AML and MDS cases. And I have some slides coming up that will kind of highlight that. And another truth, trials might not be the best option for you or your loved one. I think that's very important to understand. Trials have very explicit, there's a typo, explicit eligibility criteria, dictating whether a patient is a good candidate for this trial. And then there's a lot of exclusion criteria as well, meaning, comorbidities or past medical history, medicines that a patient might be on for another condition that will, not allow them to enroll on a trial. But it's going to take a collaborative effort, starting with the patient and the patient's family, and then extending to the trial team to figure out whether this is the best route for you. And I already touched on this a little bit, but trials may require travel. However, a lot of times transportation and lodging may be covered, at least in part, or if not in full. And then there are certain or several multi-site trials going on. That's how most of these trials work. Multi-site meaning they're at a lot of different places, and they don't always require to be at an academic medical center. There's a lot of private oncology groups here in Florida that we work with that do have trials open as well that are in the patient's backyard. So it really takes an engaged patient and their family to kind of look around and see what's available. And then another truth I think is important to share is that trials do require more frequent follow-up in these diseases, at least initially. but there is a method to the madness. The reason behind that is safety. We want to make sure that these drugs and these combinations are given safely, the patients do well, and then the patients have everything that they need. So we see a lot of our trial patients very frequently for the first month or two, and then it starts to space out once things are more under control. And then another imperative fact about trials, there's no such thing as a bad question. Questions are good. Questions engage your team. So we really encourage questions inside or outside of trials. So this is the NCCN, the National Comprehensive Cancer Network. This is it's a very helpful, algorithm in treating some of these diseases, but I bring it up because you'll see here, this is for the upfront management of higher risk myelodysplastic syndrome. And you'll see here in the upfront setting, clinical trials are there. And after disease recurrence, it is there as a recommendation from the NCCN, which is a consortium of the brightest of the bright when it comes to cancer treatment. So this clinical trials are a blanket statement is that they should always be considered, in higher risk MDS and AML. And this is for AML too. This is, where the clinical trial recommendation falls in therapies for relapse or refractory disease. And then there's a lot of upfront, recommendations for clinical trials in AML as well. So I wanted to show a quick little clinical trial breakdown. You'll hear terms like phase 1, phase 2, and phase 3. Phase 1, we have phase 1 trials open at TGH, and they're everywhere. But these phase 1 trial is a first in human trial, meaning this trial is the first time that a certain drug is hitting the veins or the skin of a human. Like I said before, these drugs have been studied in a lot of other animals beforehand. But this is the first time that they've been given in humans. These trials are generally shorter, maybe a few months to maybe a little bit over a year. But the main goal for phase 1 trials is to understand the safety of the drugs, and to also understand what dose, can we give these drugs at. And you get watched very closely to make sure that things aren't going a little haywire. And there are very strict guidelines in each trial for the investigators to hold drugs, to reduce the dose of drugs. It's not the wild, wild west. And then moving on to phase 2 trials, these are generally larger in quantities or, enrollment, and they are generally longer. So these can extend a little bit past a year or two. But this is really where we start looking at not just the safety of drugs, but the efficacy. So how effective are these drugs in treating these conditions? Do they work? Are they well tolerated? And then moving on to phase 3, this is where we start to challenge our standard of care. So these trials are going to be much bigger in enrollment. These are almost always multi-site trials. So they take large populations of several hundred to sometimes 1,000 patients. And they're looking at, a standard chemo regimen such as 7+3 for AML, which is cytarabine and daunorubicin combined. And a patient would get 7+3 on trial, and then another patient would be randomized to a different arm. And I'll kind of walk you through those terms in a minute of 7+3 plus a trial drug. So again, you're not getting a placebo, you're getting the standard of care on trials at the very minimum, but you might also get a new drug with it. These trials do last much longer. These are generally what leads to FDA approval. And, that's where they start looking at, longer term effects. One thing I did not include on this are phase 4 trials, specifically because once a drug is approved, that's when it would go into phase 4. So it would obtain approval, and then some phase 4 trials kind of look at longer term, like several years, if not longer, side effects and efficacy. And this is a very simplified flow of enrollment in a trial. So it starts off with the initial consultation. Uh, with Dr. David Swoboda, the physician I spend most of my time working with, when we see a new AML or a high risk MDS patient, one of the first questions that we're asking ourselves and then asking the patient is, would a trial be a good idea for you? We kind of see if a patient would be open to it. So we have that initial consult. We briefly discuss the trial and try to give a high level overview about what it would entail. And then we move into the informed consent process. So, we have our very dedicated trial team reach out to the patient and the family and go through this informed consent process, which is very thorough, making sure all the risks and all of the follow-ups and the requirements are very clear. And once informed consent is signed and everybody is on the same page, which is probably the most important thing in this whole process, making sure everybody is on the same page, are the pretrial diagnostics and the screening visits. There can be a healthy amount of blood work required. There are diagnostic images like CT scans or echocardiograms and bone marrow biopsies that patients have to go through. Even if they had a bone marrow biopsy done a month prior, sometimes it has to be repeated within a certain window of a trial starting. So we get that done, and then we move right into cycle 1, day 1. So the drug starts, we administer it, and then after that, it's just whatever the trial kind of tells us we need to do, whether that's see a patient every week, every 2 weeks, every 4 weeks. There's, like I said before, initially the blood work required in these trials is pretty heavy upfront for that first week, or sometimes that first month. It's blood work, at least every day for maybe a week. But it can vary from trial to trial. And again, there's a reason why. It's to make sure that things are being done safely. And here's a brief kind of glossary, if you will, of some terms that come up a lot of times in trials. So informed consent, I kind of touched on that. An in-depth document signed after you feel comfortable with proceeding with the trial. This is where there's no such thing as a bad question comes into play. Always important to ask questions. I use this word, an arm. It's not, what's attached to your shoulders. It is a part of the study that will kind of outline what treatment and at which dose you will get on the trial. So the process in which a patient gets assigned to an arm is the randomization process. So most trials, especially in the phase 3, are going to be randomized, meaning, you enroll on the trial, your name gets assigned bunch of numbers and letters, and then you kind of go through a computer, and that computer spits you out into an arm of the study. And depending on, I'll use the 7+3 example, you would be assigned to either get 7+3, so basic standard of care chemo, or you could be assigned or randomized to get 7+3 plus whatever investigational drug is being studied. And sometimes there are several arms looking at different doses when we talk about combinations and stuff like that. But the process in which you get randomized is completely random, and the reason being is to remove any potential bias that can happen in research. So a lot of studies, again, and especially once you get into phase 2 and phase 3, are going to be blinded. Some people use the word masked. So a single blind study means you don't know what's going on. You don't know what drug you're getting. You don't know what combo you're getting, but your medical team does. And then there's a double blind study where only the pharmacist knows, only the person giving you the drug knows, not even the research team knows. And then a lot of trials, or, I guess some trials, at some point in the whole journey, after several weeks or several months, if they see as they continue to continually look at the data and look at the progress, if they see that one arm is doing, overwhelmingly better, then they will kind of unblind the study and then have patients or give patients the opportunity to enroll on the other arm. So just because you go on a trial and you might be getting, standard of care plus placebo, if there's a huge benefit and it's known early on, then the opportunity to kind of shift gears can be made available to you. And then I included this at the bottom, PKs. This is how we call pharmacokinetics, which is how I would describe a series of blood work that happens early on and continually throughout a trial. And it helps the research team understand how your body would metabolize these drugs, make sure it's safe in your body. And it also helps us understand what dose should we give, what time of day should we give these drugs, and it really helps us out in understanding not just the dose, but the schedule in which we need to give patients certain drugs. So here is, skip one. So let me make sure I'm doing okay on time. So why are trials so helpful? And this is kind of coming to a conclusion. So new drugs, it gives us the opportunity to find new drugs. That is another typo. So we find new drugs that, have just been developed and made available. And then it also gives us an opportunity to use old drugs in a new setting. So take a drug that's used in a different disease, and then study it in AML or study it in MDS. And that is becoming more and more interesting as we continue to better understand these diseases and the mutations that go along with it. There's more and more immunotherapy and targeted therapies coming out there for lung cancer and skin cancer and colon cancer. And sometimes there's some overlap in the mutations that targeted therapies go after. So if a patient has a mutation in a gene in AML there's a targeted therapy available in another disease, there are some studies looking at taking a colon cancer treatment and giving it to an AML patient and seeing if there's some benefit there. And then, it also helps us, again, find the most effective dose of a new drug or an old drug, and also the best and the safest duration at which we should give a drug. Another benefit of trials is the potential for new combinations. I showed you guys a list of drugs earlier on. Again, not an exhaustive list, but there's really only a handful in treating MDS and AML. So, there are a lot of trials looking at combining those drugs with other drugs that are out there that can really help expand, our ability to treat these diseases. And then it's very important when we start talking about combinations that it's done in a very close setting, like a trial where, patients are being watched like a hawk, because especially in our patients who, when the median age of diagnosis is in the late 60s, early 70s, there's a lot of comorbidities that go along with it. So we want to make sure that we're not ruffling the feathers of somebody else's blood pressure or ruffling the feathers of somebody else's kidney disease. Trials allow us to study things and to treat patients in an incredibly safe manner, which is very, very helpful. And then the next one is very important in MDS and AML. It's what we call treatment sequencing, which is a semi-fancy way of just talking about what order should we give therapies. In a lot of these diseases that are incurable in the absence of a stem cell transplant, how can we extend the runway, if you will? That's kind of the terminology we use, to prolong survival as much as possible. And not only that, but extend quantity of life and also improve quality. And trials do help us with that, because trials will kind of look at giving certain drugs in the upfront setting versus the relapse setting, giving certain drugs, different arms. There's a big study called the MyeloMatch study going on in AML that is kind of randomizing patients to different therapies and then following them through the life of their cancer journey and looking at these patients who got X treatment first and Y treatment second, or Y first and X second, and trying to figure out what's better, what works better, what order should we give them in? Because again, we don't want to just extend the quantity of life. We want to make sure the quantity and quality go up simultaneously. And then the last way, and again, I'm sure there's several other benefits, but another benefit of trials is it can give patients early access to treatment. So FDA approval can take time. It is the government and it does move at its own pace. We can wait for drug approval for several months, sometimes longer, even after knowing treatments work. So sometimes when there are rumblings that these targeted therapies or immunotherapies are showing a lot of promise in phase 1 and 2 studies, we're able to open up phase 3 studies for drugs that might not see the light of approval day for several years, and we can get patients on these trials sooner and give them these drugs and see how well they do. And again, we're really, dedicated to trying to open up the tool chest in AML and MDS, make sure as many effective agents or drugs are available to give to patients, so that there isn't a one size fits all treatment. We understand that treatments for these diseases, the best treatment is going to vary based on the person. So, we want to make sure that we have as many options to lay out for patients as possible. And then coming to a close, how do I get on a clinical trial? I put at the top, ask your hematologist oncologist and the team treating you. That would be a great place to start. But this isn't a step one, step two. This is a, 1A and 1B. It should be an ongoing discussion, because if we don't have a trial open at Tampa General, we work very closely with Moffitt Cancer Center right down the road. We work closely with, Advent Health, which is in Orlando. We work with a cancer center down in Miami, where we try to keep tabs on what trials are open for certain patients. That way, if we think a patient is a good candidate, we say, okay, we think you would be a good candidate for this. We'll put you in contact with them, and you guys can kind of make that determination. But it should be we as your medical team should be used as a resource, not a gatekeeper. And then, DIY, do your own investigation. Then again, there's several out there. These are just some that we kind of refer patients to a lot. Clinicaltrials.gov, government run, lists all the clinical trials that are out there. It will kind of tell you, where the investigations are occurring. Researchmatch.org is another NIH, or National Institute of Health, funded organization that tries to put patients at the doorstep of certain trials and trying to figure out, is a trial right for you? I touched on the NCCN earlier. I think that's a very good resource, whether you're talking about trials or not. And the same can be said about the LLS and HealthTree, but on NCCN, they do have a tab for patients, and there's a whole, piece on clinical trials. And LLS, they have a whole clinical trial wing. They also have clinical trial coordinators that you can request as patients and caregivers, and they'll kind of reach out to you. And not only will they kind of help facilitate any enrollment or evaluation for a trial, but they're also here to kind of do what I'm trying to do now, and that's just educate, answer questions, make sure that a patient's level of comfort with the trial is as high as possible. And then, HealthTree is a fantastic resource. A lot of the awesome stuff that HealthTree is doing has already been made very apparent, but there's really on this list and all the way out there, there's really no bad place to start. And I believe that's it. So, again, I'm very appreciative that I got to do this. It is a tremendous honor getting to serve this patient population. And any chance that I get to kind of, provide some education, I like to. So
Well,
open for questions.
yes, thank you so much for being willing to come on and spending your time preparing and presenting for us today. This was incredible. I learned a lot. I'm sure this is going to be a great resource for not only those on the call, but all of the other people who were registered that can't make it today during the actual presentation, and for anyone who finds it later on. So thank you.
Of course.
So now is the time for questions. So if you have any questions about clinical trials or anything we talked about today, now is your time to ask. This time is specifically set aside for our community members to have a chance to talk to our presenters. So please feel free to ask your questions if you have any. As a reminder, you can ask your question by making a comment by typing it in the chat box, or you can raise your hand if you'd like to ask your question verbally. If you are going to raise your hand, once you're called on, you can unmute yourself to ask your question. While we wait for some questions to come in, I wanted to know, can you just talk a little bit about how someone who is interested in looking into clinical trials, but maybe the topic hasn't come up yet in any of their appointments, how would a patient go about bringing that up with their doctor?
Yeah, that's a good question. Again, we always try to make that uh, evident at the initial consult. But if it hasn't come up, which in these diseases, there's a lot to discuss. So, sometimes things slip through. I don't think there's a bad way to bring it up. We've had patients who have just said, like, do you have any trials open? We have consults that we see that say, I'm really here just to see if I'm a good candidate for any of the trials you have. But I don't think any clinician is going to be put off by any way somebody asks about clinical trials. So just bring it up and say, are there any trials open here, or do you know of any that I might be a good candidate for? And any good clinician will say either yes, we have some, or we don't have any here, but I'll do some investigation and see if we can find one for you.
Thank you. I think sometimes it gets intimidating to bring something up in those appointments. Like you said, there's a lot going on, a lot being talked about, and just knowing that it's going to be received well, most likely, and it's okay to just go ahead and ask is big for people.
Yeah.
Um, Another thing that I thought of, and that I had someone ahead of time who wasn't able to make it due to work today, wanted to know, so they are a relative of a patient, and the the conversation around clinical trials hasn't really come up. And they were asking what are the top three things that they should share or they could share with a family member who is a patient. You gave some great things already in the presentation. If you had to give, a quick three, what would you suggest someone shares with their family member about clinical trials?
Yeah, that's tough. I feel like I could do like a top 10. A top three. I would start with there's no such thing as a bad question. Starting with the question of do you have any trials open? And then number two, a trial, you're not a lab rat. This you are not, being experimented on. Trials are made to advance the treatment of, your blood cancer. And then three, um, I would say I think it would be very important to understand that trials are done very, very safely. There's very strict guidance, very set in stone guidelines on how we need to monitor patients, how we need to administer certain drugs. So understanding the safety behind trials, I think, is very, very important. So I think that would be top three. And I think there's a number three, there's some flexibility.
Thank you so much for that. Let's see. I'm not seeing any other questions in the chat. So oh, we do have one. So Alan says, I've had MDS for 2 years, currently treated with azacitidine and venetoclax. Blast went from 11% to 0%. Should I consider clinical trials in the future or wait and see if the treatment continues to work?
I think that is awesome. First of all, I think azacitidine and venetoclax in the treatment of MDS is something that's relatively new, thanks to trials. So I think one, it sounds like you've made a lot of progress. Um, it sounds like the treatment's working. It's hard to judge based on this question, but I would say, keep it in your back pocket. We do know these diseases like to come back. And when it does, post Vidase venetoclax in these diseases, treatment can be tough. So, clinical trials would be very good in the relapse setting. It'd be a very strong option, but it sounds like you're doing it very well based on that statement. So I would just keep it pushing.
We have another question. What factors should patients be considering when they're choosing between different clinical trial options?
Yeah, it's a really good question too. But it's going to be a very long-winded. I'll try to keep it not as long-winded. I think first and foremost, it's going to come down to what is best for you and your family. I kind of mentioned the logistical side of trials earlier. There can be a clinical trial open an hour away from your house. But then there could be a more enticing clinical trial, from an investigator standpoint or from a patient standpoint, that kind of excites you a little bit more, but that might be 3 or 4 hours away. It's that can kind of come down to what a patient and their family would be willing to do. Some other factors, I think are going to largely be dependent on a patient's disease, the drugs that they're giving in the trials. If there's an immunotherapy option that's made available, I think that's always worth a peek at. But that's where it would really come down to, if you are fortunate enough to have several options out in front of you, please ask your oncologist kind of what their thought is, so they can make or help you make a personalized decision and understanding, okay, this treatment might work better right now, and this other trial might still be there in a few years, or this might be approved in a few months, because that's another thing we have to consider, are the approval of these drugs. When drugs get approved, we can just prescribe them. So, if a drug that we're kind of hearing rumblings about approval within the next year or two, it might be worthwhile going on the other trial. And then if that doesn't work, then we're banking on, just basic approval of the other therapy that we can just switch to.
Thank you for that. And I think, what an exciting time to be in this field when there are options. There's multiple, trials and things like that. And um, hopefully today has helped patients to see that clinical trials are a great option, and then they can be a really good part of their treatment path. So hopefully that conversation is had between patients and their doctors, and people can review this presentation if they have any, questions about clinical trials. You did a great job covering, a wide spectrum of information for these diseases. So thank you so much.
No problem. I'm, again, very appreciative that I could be here. Oh, I think there's another
Yeah.
question.
One last one. So Maureen says, I'm a 70-year-old woman, no other health issues, none but the AML diagnosed in September of 2022. I went through the 7+3 chemo and had bone marrow transplant in February of 2023, relapsed in February of 2024, and I'm getting lymphocyte infusions in Boston. Would I be eligible for a clinical trial?
Yeah, so we have a patient who is in a similar situation right now. I'm sorry to hear that your disease relapsed, especially after transplant. I'm sure that was very deflating. But the DLI is a great option. The lymphocyte infusion is always kind of where, we and the transplant team that we work with turns to initially. I think clinical trial eligibility is definitely on the horizon. I think in our experience, there it can be kind of sticky whether or not trials will allow for DLIs. So if the plan was to continue the lymphocyte infusions, that might be one of those exclusion criteria that we talked about. So that's again where it would come down to, if there's a trial you're interested in, kind of asking the investigator, hey, this is happening. I'm getting DLIs, or there's a plan for another DLI in a month or two. Would that exclude me from the trial? And if they say yes, it would, then it would be a question for you, and your transplant team on kind of which direction would be best.
Thank you for answering that question. I think, like you said, it can be tough when you relapse in one of those situations. Another question came in. What about DLI is preventing relapse from transplant?
Yeah. So, we have some patients who undergo that as well. Our level of detection, the technology we have, which again is kind of thanks in part to research and trials, but we can kind of detect disease starting to kind of smolder or bubble beneath the surface before it's back. So we have a lot of our post-transplant patients who might have some what we call molecular detectability of disease, which is detected, from the blood or from the bone marrow. So that's why after transplant, you're getting bone marrows every 30, 60, 90, 180, sometimes every 3 months after that to see if there aren't just any cancer cells, but are there any mutations? Are there any mutated cells detectable? Because all these cases have mutations that they can be tracked to a certain degree. So even in the absence of overt full-blown leukemia cells being made in somebody's bone marrow, sometimes investigators are able to see that cells that have these mutations are starting to replicate, starting to reproduce, and that will trigger the decision to say, let's give a donor lymphocyte infusion and try to clean up this molecular presence and get rid of it. So that's where we kind of see DLIs used as well. I hope that answered both of the questions.
I think they're asking what blood tests when you talked about
Oh,
it being
okay.
detected.
Yeah, so that's going to vary based on your disease. I'll use an example. So we have patients that have FLT3 mutations. AML with a FLT3 mutation, a patient will undergo transplant. Okay, so you have those two mutations. Yeah, so that's very helpful. So they'll do a test called an NGS, or next generation sequencing, that looks for the presence of those mutations. And a lot of times, and not all the time, but a lot of times post transplant, uh, diseases will go away because you essentially get somebody else's stem cells that don't have the mutations that your cancer cells had. But some patients do have these mutations detected. I will say the two mutations that you have are two that we don't have specific tests for. They kind of just run a full mutation panel called an NGS, which I'm sure on your bone marrow biopsies, and they probably don't need to do blood tests with those two mutations, but just on the bone marrow biopsies, they're looking for them.
Okay, I think we have one last question and then we'll wrap it up for today. But if anybody else has questions, feel free to email them to me and we can make sure that they get answered. So the last question, what advice would you give to patients who may feel hesitant or fearful about joining a trial?
I would start by saying you're perfectly within your rights to feel hesitant and fearful. That means you have some sense of understanding of where things are at with the disease. One, or two, you have a pretty good understanding of what trials are. I think this should not be an ignorance is bliss kind of thing. There should be some hesitation. There should be some uh, need to ask questions, because that again means you're engaged in the decisions that are being made. But my advice would be to, be overly inquisitive. Ask questions to your hemonc, to the hematologist managing your care. Be overly inquisitive to the investigator, whoever's running the clinical trial, to your transplanter, if you have a transplanter as part of your care. There's no such thing as like too many cooks in the kitchen when it comes to a decision like this. It needs to be, a cohesive agreement made by everyone, starting with the patient.
Thank you so much for that. I think this whole presentation, the question and answer has been incredibly informative and really beneficial. And like I said, if anyone thinks of any questions later and you have them, feel free to send them and we'll make sure we get all of your questions answered. Before we go, we talked about clinical trials today, so I wanted to highlight how you can connect your records in HealthTree Cure Hub so that you can see clinical trials that you are specifically qualified for based on your genetics and previous lines of treatment. So after you create a HealthTree Cure Hub account, you're able to electronically connect your records from any facility that you receive treatment at and multiple facilities into your profile. If you live In the US, this can be done electronically and automatically. It only takes a matter of seconds. If you live outside of the US, the connection can't be made automatically, but our team of patient navigators can help you enter your records manually. Once your records are connected, you can view a comprehensive overview of your medical history, including your diagnosis, genetics, lab results, treatments, and clinical trials, all in one profile. It only takes a couple minutes to create the connection and start taking control of your disease and your diagnosis. On the screen here is the link to sign up for a HealthTree Cure Hub account. Again, these accounts are free and it's one sign-on to have access to all of our HealthTree programs, so you may already have an account, along with the email address for our patient navigators who can help you create your account and connect your records or answer any questions if you have any. We're also going to include information about Cure Hub and how to enroll in our clinical trial finder in our post-event email that will come with this event recording and a copy of the slides. Here are a few of our upcoming events that I am really excited about. September is it's a busy month, so we have a webinar on September 5th for our AML community on what if I don't qualify for transplant. We're also finalizing dates for the same topic for our MDS community, so MDS patients, watch out for that registration link in our newsletter. We'll also be hosting an all blood cancer roundtable on Monday, September 24th, and that's on the power of community clinics and academic centers working together. I'm really excited about this. We're going to have a panel including a hematologist from an academic center and then 2 general oncologists from the community setting. This is going to be more of a discussion-based event where we're going to talk about the power of involving both an academic center and your community clinic in your care. So please feel free to email me any questions you have on this topic ahead of time so we can work them into our discussion, or if you join live, you can ask them during the Q&A at the end. September is also Blood Cancer Awareness Month, and so HealthTree is going to be having an Innovation in Blood Cancer webinar that's hosted by HealthTree's CEO and founder, Jenny Ahlstrom. So this is going to be a really cool webinar where, kind of like today, we talked about innovation and what clinical trials has done. In this webinar, we're bringing on a top specialist in each of the main fields of hematology, so multiple myeloma, leukemia, lymphoma, and MPNs. And we're going to have them talk about the most exciting things happening in their field. This is going to be a really exciting webinar, so you can go ahead and register for that one as well. Like I said, September is packed full of great events and opportunities to learn. So you can click on the links there and you can sign up for any of the events you're interested in. I again wanted to thank our sponsors, Bristol Myers Squibb and AbbVie. And then finally, I just wanted to say thank you to all of you for joining and for helping us build our AML and MDS communities. I've added my email to this slide, so please don't hesitate to reach out if you have any questions about any of our programs or about HealthTree. A lot of the presentations that we've been planning over the last couple of months have been from patients who have reached out and had questions and suggested topics. So you're going to see that post-event survey after you click out of Zoom. You can enter them there, and you can also send them to me if you come up with any later. I appreciate all of you, and I hope you have a great rest of your day, and I hope to see you all at some of our events in September.